This is an explanation to go with my poster at the BAHT conference in Sheffield 2024, where I've presented my work on a survey into non-traumatic wrist disorders. I'd like to thank the BAHT for providing me a platform to speak, as well as my supervisory team at Sheffield University, including George Peat, Nick Hamilton, Ben Dean and Shona McLean. The area of interest for my PhD programme is this area in the yellow boxes. So the carpus, the radiocarpal joint and the distal radioulnar joint. And the conditions that I'm interested in as part of my programme of study for my PhD are on the slide here. So ulnar-sided pain, tendinopathy, carpal instabilities, ganglion, osteoarthritis and wrist pain. So all the things which are difficult to manage that I found frustrating when I was a clinician dealing with these. And the objective of my PhD is to answer the following question. What does care for non-traumatic wrist disorders encompass, and what is the basis for this? So, my first job in preparing for this survey was to find out what is known. And I did that by looking at the literature, both unpublished and unpublished, as well as looking at websites which were patient-facing. And I'm happy to say that I've had my publication for my scoping review last year. So if you're looking November 2023, you can see the piece of work that came to that. And then my second publication, which looks at patient-facing websites, is due for release later this year. So I'd got an impression of what is known in the literature, and what I found was that we have very little robust evidence to help us with our assessment of non-traumatic wrist disorders. There was poor evidence to understand the best ways of managing these as well. Yet we know that non-traumatic wrist disorders are seen commonly in all aspects of the care pathway. So what I wanted to determine next is what is done. So we know that the literature is not great, therefore how do practitioners perform and what do they do? So to address that question, I decided to ask them, and I've asked them through a survey methodology. Now the survey was online and we had a nice marketing and publication strategy which enabled us to get 330 participants. So this is a good number because we know there's about 700 surgeons, 700 hand therapists, and at the time about 1,000 first contact practitioners. So to get in the region of 300 participants from those groups we were happy with, although obviously having more participants would have given us greater power. We were also pleased because we got a spread between hand therapists, both OTs and physiotherapists, generalist rehab practitioners, so these might be people who treat all of the body, including wrist and hand, as well as people who are in the first contact roles, so either GPs or first contact practitioners, who also see an awful lot of wrist and hands. Now, what we found as well was that 74% of people completed the survey to the end, but there was missing data from up to 26% of our survey population. Now this is important because if people, and what we found was that some people failed to complete the survey, they tended to fail to complete the last bit because we had 20 questions. I think people got fatigued or fed up or something happened, so they dropped out. Now what that means is that if your last 3 questions have up to 30% less answers than your first 3 questions, it's harder to make comparisons or use that data. So we explored the missingness patterns and we found that the data was people dropped out related to the order of questions and to a lesser extent the professional group and care setting. So I think some professional groups had less patience to complete the survey than others. We then did something called a repeat analysis using multiple imputation. So with that, we took the data that we had from all of the data sets, including the completed and the incompleted, and we made predictions. So we used a predictive model to see what that would look like if it was repeated. And we did that 30 times. So we multiply imputated the data on 30 occasions and compared it to our original data. And what we found was that there was good relatability to our original results. And in this study, we've used the multiple imputated data because it allows us to make comparisons with our results from the start, the middle, and the end of our survey. Now, if we have a look at our data here, we found that 70% of respondents felt able to diagnose non-traumatic risk disorders. Nearly 60% felt completely or fairly confident in providing effective management, and diagnostic ability and management in confidence varied by professional group and by workplace setting. So if you have a look at the slide here at the bottom left, the ability to diagnose specific non-traumatic risk disorders, you can see in private practice people have the least confidence, whereas in secondary care you have the most. Interestingly, the confidence intervals on these graphs with the plots on each show that there was a wide degree of variability between these results, and a larger sample population would have been useful and would have expected to see lower confidence interval for these. We found also that diagnostic ability and management confidence were positively associated with the caseload. So we performed a regression analysis, and we found that the more often that people reported seeing non-traumatic risk disorders, the more confident they felt in both diagnosis as well as treatment. We also found that the most useful diagnostic means were subjective questioning, symptom reproduction and palpation. An MRI was found to be the most useful diagnostic intervention for non-traumatic risk disorders. In terms of management, local exercise prescription and attempting self-management were the most recommended treatments. And we found that outcome measures were not commonly used, especially among FCPs and surgeons, and they were not commonly used in primary care, which, if you think about the care setting and the nature of that work, is not a huge surprise. In terms of the specific non-traumatic risk disorder conditions that people felt most comfortable in diagnosing, you can see clearly de Quervain's was the most identifiable as seen by the sample, and instability and ulnar-sided problems were the least easy to diagnose according to the confidence of the clinicians. So this study is a study which is built on my initial work, which looked at what is known about non-traumatic risk disorders. This survey looks at what is done for non-traumatic risk disorders, and it gives us surface level detail. However, I think to get more understanding of the depth of why people do what they do, the next study, which looks at interviewing clinicians, will be my next publication. Following that, I will bring stakeholders, whether they be patients, therapists, or commissioners of care, together to discuss what we found about non-traumatic risk disorders and look to reach consensus on ways forward to improve cares in all parts of that patient journey. Thank you very much.